Greetings and welcome to Nursing 305 and 502, Pharmacology. We'll talk a little bit about that term in just a minute. This is the slides for the first class, which is actually done online. I'll be giving you a fair amount of information. We will meet in face-to-face next week, and I'll go over the syllabus and information again, but I wanted to give you just enough to get you started. I'm Jeff Eaton. I'm a nurse practitioner. I graduated from a diploma program back in 1978. I've done med-surg nursing. I've done detox nursing. I've done psych nursing. I did infection control. I've done inpatient nurse practitioner work. I've done family practice. I've done emergency department. I've done a whole bunch of different things. So I'll be bringing a bunch of different perspectives to this class. I appreciate the fact that there's various levels of background here, as well as a number of different majors. So it is a nursing course, so we will focus mostly on the nursing role, but I will try not to forget that some of you are not nurses. So we'll meet next week. I will go over the syllabus. The syllabus is on Blackboard. This, of course, like any online program, will be very heavily Blackboard intensive. I will answer questions in class, but there's also a section on the discussion board for questions. If you notice on the syllabus, there is expectation that you will be posting on a regular basis. Unfortunately, without having class to discuss things, we are going to have to find some alternative ways to discuss it. Some of you, this will fit really well with your style of learning. You like to do things a little bit at a time. Others really like the intense classroom experience. We'll do a few of those, but mostly classroom is going to be for expansion, exploration. Last time I did this course for the graduate students, I did it as a flipped classroom where we did all of the classes online and then discussed things in class. That's really going to be the model of what to do here as well. There's a lot of information in pharmacology. Textbooks are usually 2 or 3 inches thick. There is no way that you can learn all that information, maybe ever. And so basically my real goal is help you learn how to learn pharmacology. Try to figure out, well, when I see a drug, what do I do? How do I approach it? How do I attack it? And so we'll talk about lots of different strategies. I know that some of you have had pathophysiology and some of you have not. I very much believe that you need to understand the pathophysiology of what's going on that a drug is treating before you can understand the drug itself. So I am going to review that a fair amount. And in fact, a lot of the slides are going to be that kind of review. So medications. Now, the first thing to think about with medications is how to lump them. I'm very much more of a lumper than a splitter. So I like to lump things together and then figure out how they're all the same. And then occasionally I'll figure out, oh, geez, this one's a little bit different. It's got a little bit longer half-life, a little bit shorter half-life, slightly different side effects. So the class of a medication is usually what we're hoping that it will do. So antihypertensives. They're intended to lower the blood pressure. So there's a bunch of different things, beta blockers, calcium blockers, ACE inhibitors, angiotensin receptor blockers. There's a lot of these different things that will do that. And so they're all lumped together as antihypertensives. Now the specific instances that I just gave, the calcium blockers, the beta blockers, the angiotensin receptor blockers, these are all families of medicines. And these drugs are usually chemically similar, and really you can pick a prototype drug from those families and kind of learn that, and then figure out, oh, okay, this one's slightly different. This one has longer action or more specifics for certain bacteria when you're talking about antibiotics. And so if you can learn the basic families, then you've really got a leg up on getting control of your pharmacology knowledge. So you learn the basics of a family, and then you learn the nuances of the particular drugs. Now, one of the other very fundamental things that I'm sure you all know, but we'll throw it in anyways, is the difference between a generic name and a trade name. Now, in general, generic names are preferred, but unfortunately, trade names are often much shorter and easier to remember. And so many times what we'll do is we'll use the generic names for many medicines, but then unfortunately we'll throw the trade name in. Some of the trade names are not even made anymore. Lasix is an example of that. So the generic name of Lasix is furosemide. Lasix is a common diuretic, a medicine that's given to help people get rid of fluid. And we'll often say, give 20 milligrams of Lasix. Well, Lasix as a brand no longer exists. And so what we're saying at that point is go ahead and give 20 milligrams of furosemide. But furosemide is 4 syllables, Lasix is 2, and so you will find lots of clinicians get relatively lazy. We especially do this with a new medication when there is not any competition. So there's many of the medications out there that there's not a generic version of it. Cialis is tadalafil. Well, nobody else makes tadalafil but Cialis at this point because it's on patent. A medicine, when it's first made, is placed on patent for 7 to 17 years, depending on how it was developed, and nobody else is allowed to make it during that time so that that company can make its money back from developing the drug. Almost all of those medicines are usually referred to as their trade names. So what do you need to know about a drug? Basically, you need to know how a drug acts. This is actually usually thought of as pharmacodynamics. So if you've got a beta blocker, the action is right there. It blocks beta receptors of the sympathetic nervous system. And so that's the action. With a medicine, you also need to know how it's given. Is it given orally? Is it given intravenously? Is it given rectally? Is it given transdermally? And so you need to know how it's given. You need to know what the various doses are. Although depending on what your role is, the dosing issue is less important. Side effects, you need to know basically what side effects medicines have that you need to watch out for. Bactrim is an antibiotic that often causes a rash. Well, the problem is that rash then starts causing similar inflammation of the internal organs, and people can get really sick. So you need to know that Bactrim causes a rash, and you need to know that people should stop it if they get a rash. Now, some side effects are pretty nonspecific: nausea, malaise, those kinds of things. And that's one of the challenges, is that if you've got something that happens, is it really a side effect of the drug, or is it not related? Not all side effects are bad. There are some side effects that we like. Sometimes when you give antidepressant medicine, it also causes a little bit of sedation. And so if we give that at bedtime, not only do we get the benefit for depression, we'll also get some benefit to help them sleep. So contraindications are when not to give something. So certain medicines you can't give during pregnancy, certain medicines you can't give to people with renal disease, lots of contraindications. So we talked about pharmacodynamics, which is how a drug works. Another thing that we need to know is something called pharmacokinetics. And pharmacokinetics is not something that we spend enormous amounts of time on. But there are certain elements of it that we really do need to understand. So when you have a medicine, you need to know how it's absorbed. So if you give morphine orally, we know that it's absorbed in the stomach and then metabolized very quickly in the liver to the point where only about 10 to 15% of it actually gets into the bloodstream. So that process we need to understand. How is a drug distributed? Some of the antibiotics go very nicely into the lungs. Some don't go into the lungs very well at all. And so there's types of antibiotics called quinolones, and some are only used for urinary tract infections because they concentrate in the urine very nicely, and then others are actually good for respiratory infections. Those are respiratory fluoroquinolones or enhanced fluoroquinolones. Half-life is an important concept because half-life is how long it takes for half of the drug to get out of the bloodstream. So that if you're giving a medicine and you want it to last a long time, it needs to last in the bloodstream for a long time. So antidepressants, Prozac is a great antidepressant for young people because it has a half-life of about 96 hours. So in other words, if you skip a dose, well, there's still a lot around and it takes a while for it to drop down. Other medicines have very short half-lives. Xanax is what they call a benzodiazepine that's quick in and quick out. Works within 15-20 minutes and is gone within a couple of hours. This is good if you're giving something for panic attacks. It's terrible if you're trying to treat anxiety, because anxiety usually is not gone in 2 or 3 hours. So understanding the half-life is particularly important there. And you also need to know, are there certain groups that metabolize medicines differently? We know that elders tend to have more incidence of low kidney function, but we can't assume that by any means. There's 5 really good videos on absorption, distribution, metabolism, and excretion from handwritten tutorials by a British guy named Martin. Those are posted on the YouTube section. I do expect you to watch them. I'm sure you all are great YouTubers and know you can change the speed. If it's something that seems too simple to you, speed it up to 1.5 or 2. If it's something you need to really stop and think about, either pause it and look stuff up, or alternatively slow it down to 0.75. At any rate, I'm probably telling you stuff you already know. Pharmacotherapeutics, as we say, it's how the drugs are used and where they work. That's pharmacodynamics, isn't it? So pharmacotherapeutics is really how we use medicines. So taking all this stuff together and saying, oh, you want birth control, we're going to give you a medicine that decreases ovulation, that doesn't have side effects, that is absorbed well, doesn't have a lot of contraindications. And so these are the kinds of things that we really focus on. We used to talk about a lot of these things as nursing implications, but these are the things that really matter to patients usually. I'm not really going to talk that much about cost in this course. I did add GoodRx as a link. There's a couple of good links. Hippocrates is a great link that I would highly encourage all of you to establish a Hippocrates account. It's free. Almost everything that I'm going to recommend this semester is free. We will be doing some readings from the Lehne or Lehne book, but I'm going to try to keep those to a minimum. And as I say, I'm going to try to help you learn to utilize a lot of other free and easily accessible internet access resources. Cytochrome P450 is something that we'll talk about some. At the graduate level, it becomes a lot more important. But for you guys, you just need to know that it exists and that there are a number of different interactions with medicines. Sometimes you have 2 medicines that are being metabolized by the same cytochrome P450 enzyme. It's going to slow down the process. Others, the first medicine will actually ramp the amount of enzyme being produced, so it actually decreases the levels. So it's a pretty complex concept. We'll try to keep revisiting it as time goes on. Right now there are tests that you can do to see how effective someone's cytochrome P450 is, but we're not doing them very much. I think that's something we'll do down the road. So again, back to pharmacodynamics, you've tried to figure out what the target organ is, where's the site of action. Essentially, everything that we put in our body, there has to be a receptor that naturally would have a hormone or an enzyme that would stimulate it to get that effect. So for example, we're learning more and more about the cannabinoid system. We naturally have cannabinoid receptors in our body. If we didn't, marijuana would not do anything to us. It would have no place to go. There's a few medicines that directly affect something, like the antibiotics will directly affect the bacteria, but almost everything else is going to either stimulate or block one of the receptors in the systems. Agonist is another way of saying something that stimulates the receptor, and an antagonist is another way to say it blocks it. It's also important to think about where other sites might be, where side effects might occur, because if you're giving a beta blocker, it's not going to know that you want it only to go to the heart. It's also going to go to the lungs. It's also going to go to some of the other sites in the body that it might have an impact on. So this is a way to figure out where side effects might occur. All right, how's a drug given? Lots of different ways. You can give it orally. Oral is also referred to, if it's in the GI tract, as enteral. So even though it's not given oral, if it's given into the stomach, if it's given into the jejunum through a tube, we consider that an enteral drug. Topical drugs, obviously on the skin, sublingual under the tongue. Most common one of that, of course, is nitroglycerin. Subcutaneously, which is injected but into the fatty tissue, intramuscularly into the muscular tissue, intravenously into the veins, epidural into the epidural space of the back, and then intrathecally is actually into the spinal canal itself, where the spinal fluid is. Now, as we mentioned, not all side effects are undesirable. And that's why we often use the term adverse drug reactions for the things we don't want. So those can be very lethal, like a possible cardiac dysrhythmia, and others, if you've got a little bit of dry mouth, if you suck on some hard candies, that'll take care of it. So we do need to learn what the adverse drug reactions are and what kinds of things need to be done to address that. Contraindications, and in an absolute contraindication, you'd never give that medicine to a patient. There are some things that are only relatively contraindicated. Quinolone for antibiotics, for example, are essentially never given to children, except in kids with cystic fibrosis who really need them and there's no better option. There are certain downsides, but breathing is good, oxygen is good, and so we do balance those sometimes. Now, one of the things for contraindications is pregnancy. All drugs are categorized as far as their safety level in pregnancy. A means it's safe based on human studies. You don't find too many of those just because it's very risky for a drug company to do a study on humans and then find out that it caused problems. They're going to get in all sorts of problems. So B is probably the highest level that you're going to usually see. These have been thoroughly studied in animals, not seem to have any substantial side effects or problems, and they're generally considered to be okay to use in pregnant women. C's, you really have to balance the potential risks and the benefits. If it's something that is potentially dangerous or lethal, an antibiotic that the patient really needs, we might go ahead and do it. On the other hand, if we have an alternative that's a B, we're probably going to choose the B. D would usually be used only in extreme cases where, life and death was in the mix. And then X is a medicine that should never be used in pregnancy. It either causes birth defects, or it causes abortions, or it causes something else. Some medicines like this are actually used to induce abortion through medical abortion, but that's a little bit of a different discussion. So, nursing mothers, I can't emphasize enough that you cannot use the pregnancy classifications to determine whether a drug is safe in nursing. You have to specifically look it up because there's some that are safe in pregnancy but concentrate so much in the mother's milk that they're now dangerous for the baby. So, an alternative, there's some that are totally unsafe in pregnancy that once the child's born, you can go ahead and use them. So either way, you do need to figure out for nursing mothers, what's safe and what's not safe. If people have decreased liver or kidney function, there may be medicines you can't use or that you need to alter the doses. With glaucoma, especially untreated glaucoma, there's going to be some that'll make that worse. Allergies, obviously, if somebody's allergic to something, you shouldn't use it. There's some medicines that have cross allergies. For example, cephalosporins are more likely to have allergy problems in people that are penicillin allergic. Arguments as to whether that's somewhere between 2 and 19%. But at any rate, if you had somebody that had penicillin and had an anaphylactic reaction, you're probably not going to give a cephalosporin. And again, there's some people that have a problem with metabolizing certain substances that we found through testing. So you want to know how a drug works, what problems it can cause, times when you shouldn't give it, how to give it as far as dose, route, and timing. And these translate into the 5 rights. Some people use 6 and even 7 rights. But you want to make sure you're giving the right dose of the right drug to the right patient at the right time via the right route, and many times for the right reason, and then with the right documentation. Nursing students will get a lot more of this in your clinical courses. The apothecary system is pretty much gone. So this is milliliters, this is ounces, drams, minims, those kinds of things. We do sometimes use ounces. 1 ounce is 30 milliliters, so we can easily convert that. But we're really going to be in the metric system. Apothecary system is pretty much gone. You will need to know how to convert micrograms to milligrams. You basically just, move the decimal point 3 places. And so 150 micrograms is the same thing as 0.15 milligrams. And again, how long does something last? The half-life concept is going to be very important because something with a long half-life you're going to give once a day, something with a short half-life you're going to give 2 or 3 times a day. Drug interactions versus compatibilities. This is mildly important. Interactions basically is if you give 2 medicines to the person at the same time, it's going to change the way the drug works. One of these might be giving somebody vitamin C when they're getting iron. It's supposed to improve the absorption of iron. It's supposed to help the iron work better. Compatibility is when you're mixing up IVs or other solutions. Is it going to cause it to precipitate? Is it going to cause crystals to form? And so compatibility is a slightly different concept than an interaction. So we talked about there being receptors in the body. A number of these receptors can give a euphoric feeling, probably opioid receptors, but especially certain types of those mu receptors will give a euphoric feeling. Some people seem to have a lot more of these than others, and so when you give them narcotics, they seem to get a high, they seem to get a feeling. I've had patients say that they felt the absolute best they ever have in their life when they had Vicodin or oxycodone on board. Other people don't seem to have them at all. Other people don't really seem to get those euphoric feelings. A lot of these receptors can upregulate or downregulate. Benzodiazepine receptors, which are also known as GABA receptors, are notorious for downregulating. And then when you take people off benzos, they have horrible withdrawal and really nasty feelings. So we'll talk more about that as time goes on. Drug schedules. Schedule 2 are the strongest narcotics and controlled substances that can be prescribed. Schedule 1 has no known medical use and is federally illegal. As of right now, cannabis is a Schedule I medicine as far as the federal government is concerned, as far as the Drug Enforcement Agency, the DEA is involved. They say it's illegal. A lot of states have legalized it. It's a real conflict now between state law and federal law, but hopefully we'll be able to get this one figured out at some point. Schedules 3, 4, and 5 are progressively less dangerous. Schedule 5s are actually available behind the counter in some states, meaning that you have to sign for them, but you can get them without a prescription. Robitussin with codeine is like that in Maine, although most pharmacies choose not to do that. They could legally do that, allow people to sign for it. And drugs of the week. So I'm going to post a bunch of different drugs of the week every week. On Blackboard, these drugs are listed in the discussion section. I would encourage you to look at them and add something to each of those discussions. What's the half-life? What are the side effects? What are the things that you think people need to know? With ethanol, how do we measure the laboratory testing? What does that mean? And so there's 6 here. Give you an opportunity to play with that a little bit, and we'll see how that goes.